This episode is brought to you by Sabio, the #1 coding bootcamp for veterans. Visit sabio.la/military to learn more. I'm Rod Rodriguez.
I'm Jack Murphy.
This is Military Matters. One of my favorite audio projects was a show I pitched to connecting vets. We'd have veterans tell a story from their life or career that changed who they were or what they thought was true. Profound moments in their own words. One of those stories was from a veteran who served one tour in Vietnam and was suffering the effects of Agent Orange decades later. You could hear it in his voice, the strain it took to breathe, much less talk. We talked about his frustration at the time of Agent Orange victims being told that their illnesses were due to other factors, even being told that the Agent Orange symptoms were age-related. He was angry that so many other veterans like him were being denied care because the VA refused to link their illnesses with their service. Now that fight continues as more conditions and locations are being added to the VA's presumption list, basically a list of medical conditions and locations that the service member was stationed at that allows them to be exempt from having to provide the typical elements of evidence to support a service connection. Now, unfortunately, the GWAT, or Global War on Terror generation, is looking down the barrel of their own Agent Orange situation. And that's the number of breathing issues that have come to light since 9/11, and some might argue going back to Desert Storm, really. This issue is often talked about in the light of burn pits. Burn pits were a popular way of burning trash and debris during the early years of the Iraq-Afghanistan wars. I myself slept near a burn pit where our everyday trash was burned in addition to lithium batteries, plastics, tires, fuel, and the occasional dog corpse. I was a young Joe at the time, which meant like most E5 and below, we were charged with burning barrels of our own feces using a mix of JP8 and MoGas. In 2014, the VA started the Burn Pit Registry for veterans to document where they were stationed between 1990 and today, with certain theaters to start documenting their exposure and to determine service connection with illnesses. And you might be thinking, well, I was stationed in those areas, but I wasn't near a burn pit, so I'm okay. Or perhaps you were near a burn pit, but you're not aware of any health issues. Our guest today says you might be very wrong, and that your assumption could cost you dearly in the future. Today, we're talking about breathing. And what we've been breathing in these last couple of decades, well, it's not good. I sat down with Dr. Richard Meehan. He's a rheumatologist, a doctor who specializes in the diagnosis and treatment of diseases that affect the muscles, bones, joints, ligaments, and tendons. He's the co-director for the Post-Deployment Lung Health Center at National Jewish Health, a leading respiratory care hospital in the country. He's also a Navy veteran himself. So bottom line up front, if you deployed anywhere in Southeast Asia, to include the Middle East, you're at risk. And here's why. One of the big things that we've heard in the last couple of years has been the impact of burn pits from Operation Enduring Freedom, Operation Iraqi Freedom. And there's been some comparisons to Agent Orange of the Vietnam era in that it took a long time for the VA and Congress to acknowledge the illnesses that were stemming from Agent Orange. Can you tell me a little bit about what some of this research has uncovered in relation to these burn pit illnesses?
Well, we've been primarily focused on the veterans themselves with respiratory problems, but a lot of people aren't aware, but the air quality in Southwest Asia, Iraq, and Afghanistan is so poor, it exceeds military exposure guidelines. OSHA wouldn't let you work there, but of course, you go to war, you deploy where you're sent. And so the particulates really exceed safe guidelines, and especially if you combine that with another toxic exposure, which is burn pits, where they basically were burning everything on the base. You didn't want to risk losing people, sending them outside the base to dispose of them in another manner. So it was really a pragmatic approach until they had their first incinerator in Balad in 2009. But people that were right next to the burn pits were exposed to combustion products of volatile organic compounds, plastics, medical waste, as well as poor industrial controls from nearby cities. And not only that, but all the combat operational inhalation exposures. I mean, CBs are involved in welding and vehicle maintenance and solvents to clean the vehicles and so forth. And that's true with a lot of combat forces. So it's a pretty toxic environment that you're inhaling. As a matter of fact, when we brought all 542 CBs back, you have to fill out a post-deployment lung health assessment. And by far the number one complaint, worry of deployed forces was what was the effect of the air quality going to have on their long-term health, even though I wouldn't allow people to deploy with us that had pre-existing lung conditions. But afterwards, I did see some new onset asthma while I was there. And like a lot of airborne inhalation exposures, like cigarette smoke and asbestos, sometimes it takes decades for those exposures to show up. And so I'm pleased that at least we're not waiting quite as long this time as what happened before. And so I think this is a big step forward because a lot of deployers that we've seen do have unexplained shortness of breath. And they need a very comprehensive evaluation to try to figure that out. Because since these are healthy people, another interesting fact is that our, quote, normal guidelines are based on sedentary, non-athletic Americans. And so when you take an airborne special forces guy that is incredibly fit, and now they can't complete their physical fitness test. They were running, 5-minute miles, 6-minute miles before, and now they're basically going to have to be discharged from the military because they can't complete their test. But yet all their standard breathing tests come up, quote, normal, meaning it's within 85% of a normal sedentary, inactive American. And so it takes sophisticated testing to figure out what's going on with these individuals, and sometimes even a surgical lung biopsy to show that, in fact, they do have airway injury from their inhalation exposures. And that's what our main center has been focused on since its onset, is trying to thoroughly evaluate these veterans, find out why they're short of breath. For example, the big center in San Antonio, when they evaluated these people, they didn't have an answer in 40% of them. And so those of you that have ever been evaluated in military medical treatment facility, if they don't have an answer, they say, oh, well, it's probably, PTSD, or you're just out of shape, or, anxiety or something else. And yet if you push harder, you can actually find there's anatomical damage to the lungs, and that explains their impaired exercise capacity.
You were saying that the air quality in Southeast Asia is just unsat. It's actually breaking OSHA standards. Are we talking about just the normal air quality?
Yes, just because of the PM2, that's particulate matter, 2.5 microns, so small particles that they can get into the distal part of the lung, where you can't cough them up. They don't get trapped in the mucus. They can actually have to be cleared by your immune system. And it's been shown in lots of studies that when you have high short duration exposure, such as big cities that have elevated PM 2.5 levels from like what we see in Colorado with our forest fires and poor air quality, that results in an increased risk of cardiovascular, even death. People go into the ER with asthma flares and cardiovascular mortality. So, and that's because of the poor air quality over there in combination with all the other factors that I just mentioned that make that air even more unhealthy to breathe.
What are these particulates? We're talking about just the air of Southwest Asia without the burn pit factored in. What are these particulates? What is it in the air that is making it so bad to breathe?
Yeah, it's primarily dust. And this is dust from ancient seabed that's kind of novel. And this does get blown all the way around the world. But it's because it's so fine that it can work its way into the smallest areas of the lung. And it can also entrain or capture, if you will, other things that normally you wouldn't breathe into the deepest part of the lung. We have a pretty good protective mechanism to keep out bacteria, viruses, fungi, toxin stuff. They get trapped in the upper airway sinuses, the mucus in the lungs, and the upper airway. But if they're part of these particles, then they can make it all the way down to the distal lung, where it's your own immune system has to clear it out. And that's not very efficient. And in the process, that can sometimes stimulate inflammation in those very tiny airways that are involved in gas exchange. So the airways themselves become thickened, they become inflamed, or they become scarred, and they're no longer efficient at gas exchange. And they also result in what's called air trapping, where you can't get the air out of your lungs. And so you have impaired exercise capacity.
What about the people who live in Southeast Asia? What about the natives, if you will? How are they not affected by this? Have they adapted to it? What's the difference between us and them in terms of our exposure to the same air?
Well, there's not a very good health surveillance, public health system in Iraq and Afghanistan. There just weren't good studies to answer that question. One of our colleagues in the Army actually wanted to do spirometry on local Iraqis to compare that with our studies and was denied. The Army said, "Oh, well, we can't protect their subject protective rights." So I don't think they wanted to know. But hopefully, with a little bit more sophisticated infrastructure, that may be a while for Afghanistan and Iraq, but we'll find out. But the life expectancy is really very low in those countries compared with countries that have good public health standards and tracking.
I've always been curious about something that I was tasked to do as a young soldier, and that was burn feces. I remember we had these gallons, these metal containers cut, these, what are the 25-gallon, 50-gallon drums, 25-gallon drums, whatever. And, we were mixing, it was a mixture of JP8 diesel and Mo gas, which is like regular gasoline. And we had to mix it. And I was exposed to tons of that smoke. I mean, that stuff just, and it was me and a bunch of E4 and below, a couple of E5s that were out there stirring this nastiness and, breathing in the smoke. And after a while, you just forget about it. You're not thinking much about what it is that you're breathing in. Can you talk to me about some of the dangers? So what the particulates, is there anything that we need to think about in terms of burning human waste and exposure to those fumes?
Those fumes are, that's well known that that's toxic to be breathing those fumes. That's why you can't do that here in the States. But as far as, it's very noxious what it smells like. And I think it might be more just what you're burning to get it going, and that may put those in smaller quantities so that other things are getting in your lungs. It's the novelty of something that can overwhelm an immune system. So normally you don't breathe incinerated feces. So what's that going to do when your immune system is seeing something kind of novel? We're pretty good, our immune system, at seeing even organisms we've not seen before. That's why, the whole planet doesn't die when there's a new virus or a new protozoa or bacteria around. We can sometimes respond to that pretty well. But I don't know a specific study, to answer your question, that has looked at the health consequences of burning fuel. But I know that burning feces, but usually in those drums, you're burning other things too. They just want to get rid of paper waste and maybe other things that people don't want to have to truck out of a combat zone. So you may have been burning some other things too. At least in a forward operating boast, you would.
If you're looking to make a career change or still trying to find your path outside the military, I recommend checking out Sabio, the coding bootcamp and developer community that's helped so many veterans become successful software engineers. Sabio teaches you the skills to start a real high-paying tech job in just 17 weeks, online and from the comfort of your own home. Visit sabio.la/military to learn how you can use your VA benefits to enroll. That's sabio.la/military. Can you talk to me a little bit about what it is that you're seeing in these veterans that are coming to these centers? What kind of lung issues, what kind of breathing problems? Are we talking cancer? Are we talking emphysema? What is happening to these veterans who have been exposed to these levels of toxic air?
Well, we're evaluating patients similar to what Bob Miller did at Vanderbilt that have unexplained shortness of breath, they haven't been given a diagnosis. So if you thoroughly evaluate these patients, even with non-standard tests, we're doing, one of our goals is to try to do non-invasive testing. We have a technique called lung clearance index, which is the ability to get rid of an inert gas after so many breath exchanges, and then also using advanced computer artificial intelligence to quantitate the amount of air trapping left in a CT scan after you exhale. But to get back to your question, as far as what we're seeing, some people have asthma that's been difficult to diagnose. Most of them that we would see, we never see a normal surgical lung biopsy. So if we have to do a lung biopsy, there's always abnormalities in the distal lung, which would be either inflammation scarring along the lining of the lung, most predominantly in the airway itself, that would lead to this air trapping and impaired exercise capacity. And sometimes we see typical, what we call hypersensitivity pneumonitis, and that would be like an allergic response to something you inhale. Like some people are allergic to birds, and they have birds, so they get pretty severe lung injury. We see similar things, even emphysema, in our deployers who have never smoked. And that surprised me because that's not something that we normally would see before. But when you damage these small airways, you can see some unusual things. So we always see some abnormality when we have our deployers go to a surgical lung biopsy, but we would like to come up with ways to prevent that so we don't put them through a surgical procedure to get a chunk of their lung.
How recoverable are some of these injuries, or are they life altering?
Well, we don't get people back to where they were pre-deployment. Our goal now, knowing that it's a scarring type of toxic exposure to the lung, we want to do everything we can to maximize all the other treatable conditions. But like we'll tell them sometimes they're not happy with it, that they shouldn't go back there, that they're going to get worse. This is what happened with their first or third or fifth deployment. They go back again, either as a contractor, which they want to do because they can make a lot more money, but say you may have irreversible lung damage to where you may die or need or need a transplant to live. So that's some things we're doing. As a rheumatologist, my specialty was in treating autoimmune lung disease. So I was really disappointed that more of these patients early on, I was treating them with immunosuppressive therapy, but it didn't make any difference. They didn't get better because it wasn't an active, ongoing inflammatory process. It was damage to the lung that had already occurred. So once they come back from the States, if they're not exposed to other toxic things, like we don't want them to be wildland firefighters, but if they can have a safer exposure environment, then they'll do better. We all have a decline in our lung function as we age. Every year we lose a certain percentage of lung function. If you start out with an impairment, then that's going to accelerate. So they're not going to get back to where they were before pre-deployment, but a lot of times we'll find some other unusual things. There's a condition called expiratory central airway collapse, where their upper trachea is the problem. And sometimes we can fix that surgically. Sometimes patients have a combination of these things. And of course, what we'd be most excited about would be to see something that we have really good therapy for, because those are really inflammatory diseases that if we treat them with the immunosuppressive therapy, they'll get better.
Are there any recommendations that you would say, hey, DOD, you need to start implementing these types of changes, or your force is going to be depleted or weakened or compromised in the future?
Well, the one case that we've made unsuccessfully through the Department of Defense, we've testified at the Defense Health Board. My colleague Cecile Rose has been on the National Academy of Sciences committees, is to recommend that they get baseline lung function tests before they're deploying to a place that has substandard air quality. Had the World Trade Center workers not done that, the paramedics, first responders, we wouldn't have known that exposure resulted in a significant progressive decline in lung function. Because Department of Defense hasn't done that, we don't really know the magnitude of ongoing loss of function. So we've made that case unsuccessfully.
This may seem like an odd question, but did COVID help at all with folks wearing masks as often as they did all over the world? I mean, we're talking about 2 years of people were pretty much wearing masks nonstop. Uh, it, is that helped at all with folks with lung issues?
Well, I think it certainly during that period there was a dramatic drop down in respiratory illnesses. So most of my colleagues that are ICU pulmonologists, they weren't seeing the normally we have between 40 and 60,000 flu deaths every year, despite we have immunizations. But when people were in lockdown and wearing masks, that really dropped dramatically, 2020, 2021 for combat forces, and you would think, oh, well, just have them wear masks. It's impossible to work wearing a surgical mask or even a cloth mask when you're in that high dust environment. If you're a ball turret gunner, on a convoy, and you've got so much dust in there from the vehicle in front of you, what they do is what the locals do. They just wear a cravat around their nose and mouth, and when it gets full and they can't breathe, they shake it off, put it back on again. And we don't have good respiratory equipment for somebody who's working and fighting in that environment. So, I mean, that would be ideal, but that doesn't exist.
What does the future look like for your research? What are you guys doing? What's the cutting edge of respiratory research in regards to burn pits and the warfighter in general?
First of all, we're trying to identify some non-invasive testing that can prevent the need for a surgical lung biopsy to diagnose these individuals. As I mentioned, the lung clearance index test and the AI computer reading of CT scans, those are non-invasive. But then the ongoing research, we're collecting samples from the nose, sputum, and what's called lavage, where we put a tube into your lungs and wash it out and look at that to find out what the immune response is. So the difference between people who are having these symptoms and people who didn't. Oh, because considering everybody has the same environment, we're not seeing, it's not 100% that people have respiratory disease. In my own unit of 542 CBs, it's a small number that have had respiratory problems. I've not seen anyone with serious, like constrictive bronchiolitis, like we're seeing at National Jewish Health. So the individual susceptibility, that's going to be diagnosed probably more at the cellular molecular level. There's a way that some of us react to environmental, you could look at it as like almost allergic reaction, that some people have allergies to things they breathe in and other people don't. And so we're trying to understand that so that we can come up with better ways to intervene early. People identify people that may be at higher risk, for example, so that we would prevent them from being, exposed, and also to have better treatment. Right now, an important disease that has a high lethality is pulmonary fibrosis, called idiopathic pulmonary fibrosis. If it's not due to an underlying autoimmune disease, then it has a very high, 2.5 year, 50% mortality, or certainly by 5 years, 50% mortality. Now we've finally got some drugs that are anti-fibrotic. And so we're hoping that maybe we can improve some of the small airway injury through anti-fibrotic therapy. We've not undergone that treatment trial yet, but we are doing a treatment trial of some novel therapies for deployment-related asthma to see whether that might be helpful. So we're looking at novel treatments, better ways to diagnose, but for the individual veteran, they want to know, what can I do to get better? And a lot of times there'll be some other underlying things. They'll have sleep apnea. Well, if that gets treated, then they have more energy. They can exercise better so they can preserve the lung function that they have. And so we try to focus on that as well, as does the VA. I mean, there's about 5 centers across the US that are now specializing in deployment lung disease. One of them is right here in Denver, that's run by our National Jewish pulmonologist, Silpa Kraft. So she's been on these major committees to advance care for veterans through the VA system.
There are some veterans out there who were exposed to these burn pits, to burning feces and all manner of dust and particulates and debris. Some of these guys are sitting there right now listening to this, and they're thinking, I'm fine. I breathe, I can run, I go back. I'm fine, doc. But should I be concerned, and what should I look out for?
Well, you have to compare your level of activity to what it was before you deployed. And so we know once we stop doing our physical fitness tests once or twice, twice a year, that's a good incentive to exercise regularly. When you leave the military, you may not, unless you're really, disciplined to say, no, I'm going to keep up the same level of fitness. But you should be able to do almost the same level of activity if you're maintaining some regular exercise. If you start having a decline in that, and especially the most common complaints would be, I'm short of breath only when I exercise, and then I'm short of breath with less exercise. Now it's short of breath going upstairs. That needs to be evaluated. I've got a chronic cough. This cough, I've seen multiple docs. They don't know what it is. I've tried antibiotics, tried steroids. I've still got it. That needs to be evaluated. And so if you've gone through, your regular primary care doctor for a complaint you're concerned about, then I think it should be evaluated if it's something that's not getting better, not responding to therapy. And I've also encouraged all of my CBs to really go to the VA, even after they deployed when they had no problems, because that way they've got a baseline. So something in the future pops up, and then they're in the system, they had evaluation, and so they know what their baseline function was. Because otherwise you're just going in there and they say, well, wait, you're a 60-year-old guy. You're going to get all sorts of problems because you're 60. Well, as I mentioned before, the healthy worker effect, people in the military are not average Americans. They're much more fit and healthy. Even veterans that are active duty that have a health problem, if you can't deploy, they're discharged. And so this is a healthy worker population that is now can't even return to do something like being a police officer or a firefighter or something, because you have to have a certain amount of fitness to do those.
So your advice is to go to the VA, try and get that baseline done, at least start getting the ball rolling, so that way they can compare this later on in life and say, hey, yes, there is a declination in performance of your lungs or in health. It's not related just to your age. It's also related to your service.
Right. And for example, they have registries at the VA, and I'm in them, burn pit registry, and so that way the VA gets a better picture of maybe the difference between those of us that were lucky enough to spend a year in that bad toxic soup and didn't get medical issues versus those who did. And there's probably a difference in their genetic immunologic response to the same environment that the others had. But I think that having a baseline evaluation when you've been in a combat zone through the VA, and if you're healthy, great. But that way they can compare you with people that aren't healthy. And you don't know what's going to happen. Like if you look at these cancers now that are presumptive and they're entitled for compensation or VA care or both, those are common cancers. I mean, GI cancers, head and neck cancers, lung cancers, brain cancer, not as common, and if those people hadn't registered in the VA, they wouldn't be able to take advantage of that benefit they've earned. Now, the VA is not going to be happy with what I'm telling you because they're feeling overwhelmed. There have been, I think, 150,000 people seeking evaluations for disability. They need to ramp up. That's part of this act, as far as I'm concerned. It's not just to say you're entitled to, if you don't get the care you need in a timely fashion, then that needs to be a funding issue through the VA rather than a crisis response. I don't want to hear that people are waiting a year for an evaluation at the VA when that may be a great source of care for them. I get my care at the VA, and I encourage other people to as well. You're entitled to that access to care, and that's a right you've earned. So I would encourage people, if they deployed to a combat zone, at least to have a baseline evaluation at the VA. And then you're in the system if something comes down the road in 5 or 10 years.
Where can folks go to find out more information about what you're doing with your organization, your research, and to maybe find out more about the burn pit registry and about their health in general?
Right. So I think the registries at the VA and everything about the PACT Act, you can get that just by going to the va.gov site or my vet, my healthy vet. Our information about our Center for Deployment Lung Health at National Jewish Health, we have a website for that. And so if you just Google National Jewish Health Deployment Lung Center, that would put you right into our website. That would explain all the research that we're doing as well. And we still are seeing veterans have unexplained shortness of breath. Most of our patients come from either active duty military sites that are referring to us or from other combat veterans that know about our center.
Dr. Meehan, thank you so much for your time. Is there anything that you want to talk about or address that we haven't talked about and you think folks need to understand or know?
Just don't accept the 40% that was told to you at a prior medical treatment facility that your tests are normal, so it's got to be in your head. Okay, veterans know their level of fitness, what they were doing before, and they know, wait, they used to run a 6-minute mile pace and now they can't pass the physical fitness test. No, there's something wrong. And if your doctor says there's nothing wrong with you and you can't exercise regularly, you need to go to one of these 5 VA centers or some of the civilian centers like National Jewish Health in Denver or Vanderbilt to get a more thorough evaluation to find out why you have impaired exercise capacity or you have unexplained respiratory issues. And there's a lot that's compensated through the PACT Act other than just cancer. I think that's gotten a lot of the press because of Joe Biden's son, but sinusitis and asthma and bronchitis and emphysema and other things are also related. I was surprised that we're seeing all this pathology in non-smokers. My prediction was, I knew it was a bad environment to inhale. I thought only the smokers in my unit would be the ones affected, and it was not at all.
I think that's interesting. I think a lot of folks, they think that they're not at risk as long as they didn't do those things like smoke or drink or vape or any of those things. But fact is, the fact that you were there, the fact that you were exposed, that could be enough to push you over the edge.
Totally. Most of the people that we're seeing were not smokers. And so these are lung injuries in non-smokers. Whereas I think it'd be very tempting for a pulmonologist or a doctor who hasn't evaluated a lot of these patients, if they are a smoker, to say, oh, this is just smoking related. And it takes a thorough evaluation to tell the difference between smoking related emphysema, smoking related chronic bronchitis versus constrictive bronchiolitis due to toxic exposure from deployment. And I don't think you're going to get that from most community evaluations.
I want to thank Dr. Meehan for his time and expertise. If your doctor or the VA have an issue with you getting a checkup or baseline established, direct them to this episode. All the links are in the show notes. Folks, your health is a priority. Treat it like one. Be sure to check us out on social media. We're on Twitter at StripesMMPod. And if you have a tip or story idea, shoot us an email at militarymatters@stripes.com. Don't forget, you can get 50% off your digital subscription to Stars and Stripes today. Just use promo code PODCAST and get 50% off your digital subscription. That's promo code PODCAST. This episode is brought to you by Sabio, the #1 coding bootcamp for veterans. Visit sabio.la/military to learn more. Thank you for listening. I'm Rod Rodriguez.
I'm Jack Murphy.
And we'll see you at the next episode.